My name is Caroline Lozer, and I'm with the Lewin Group. Welcome to the webinar involving and supporting family caregivers in care planning and delivery. This is the fourth webinar in the 2017 Geriatric Competent Care webinar series. The audio portion of the presentation will automatically stream through your computer. Phone lines for this presentation are also available. To access the number, click the black phone widget at the bottom of your screen. Today's session will include a 60-minute presenter-led discussion, followed up with 30 minutes for a discussion among the presenters and participants. This session will be recorded, and a video replay and a copy of today's slides will also be available at www.resourcesforintegratedcare.com. Continuing medical education and continuing education credits are available at no additional cost to participants. If you are interested in receiving credit for this webinar, AGS is accredited by ACCME to provide continuing medical education for physicians and by NASW to provide continuing education for social workers. CMS is also accredited by IACET to issue CEUs. So you'll see on this slide that we've laid out various continuing education credit options. If you are a social worker, you can obtain one continuing education credit hour if you complete the pre-test at the beginning of the webinar and complete the post-test. If you are a physician, you can obtain CMEs if you complete the pre-test at the beginning of the webinar and complete the post-test. CMS is also offering CEUs for other individuals looking to obtain credit for attending this webinar. In order to obtain these credits, you must complete the post-test through CMS's Learning Management System. Additional guidance about obtaining credits and accessing the links to the pre-test and post-test can be found within the Continuing Education Credit Guide in the resource list of the left-hand side of your screen or at the Resources for Integrated Care website. So this webinar is supported through the Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. MMCO is developing technical assistance in actionable tools based on successful innovations in care models, such as this webinar series. To learn more about current efforts and resources, please visit our website or follow us on Twitter for more details. Our Twitter handle is @integrate_care. All right, so at this time, I'd like to introduce our moderator. Carol Regan is a Senior Advisor to Community Catalyst Center for Consumer Engagement and Health Innovation and has over 30 years of experience with national and state-based public policy and advocacy organizations. Carol?
Thank you, Caroline, and welcome. Good morning and good afternoon to some of you, depending on where you are. I'm delighted to, again, moderate one of our many geriatric competent care webinars. As I was introduced, Community Catalyst and our center is an organization that is committed to working on bringing the consumer voice into healthcare decisions that affect their lives. And over the past few years, we've been delighted to work with the Lewin Group and the Medicare-Medicaid Coordination Office to put forth policies and practices that really improve the care for older adults, and have committed to working on that. And this is one of the ways we're able to kind of continue to push out education and good models. So we're delighted to have today this webinar. I'm going to quickly introduce our incredible faculty, and then we will do a couple of polls so we can get a sense of who's on the call today, and then turn it over to our faculty. And I'll introduce them in order. So Dr. Anita Major has studied medicine at Baylor College of Medicine in Houston, Texas. After an internal medicine residency in Manhattan at Cornell's New York Hospital, she completed a 3-year geriatric fellowship in Miami at Jackson Memorial Hospital and the Miami VA. She returned to Houston in 2010 to serve as the director of geriatric house call program at the Baylor College of Medicine. She's a clinical educator and has experience in interprofessional education, and her clinical practice consists entirely of supporting homebound, frail elders. Dr. Major finds empowering caregivers was one of the most gratifying aspects of her career. And at personal level, she cares for her mother-in-law at home who suffers from a traumatic brain injury. And she spends time with her husband, who's a retina specialist, and she has 3 young children. So we'll welcome Dr. Major. Allison Dobecka is a nurse practitioner and has been employed by Baylor College of Medicine in Houston with the Geriatric House Calls team since August of 2014. She worked with a private company in the same capacity in Dallas the year before joining Baylor, and prior to this, she was a registered nurse at St. Luke's in Houston for 7.5 years. Allison earned her Master's of Nursing in Adult Primary Care from the Texas Women's University in Houston after earning her bachelor's degree in San Antonio, Texas. Allison teaches geriatric medicine focused on in-home care to medical students, residents, fellows, as well as nurse practitioner students. And then we have Siona Regev. She's a licensed clinical social worker specialized in gerontology, and she's got extensive experience in geriatric clinical care over 30 years in program development, interdisciplinary collaboration, case management, consultation, and education. Siona delivered and championed services for primarily for older adults and other age groups with physical and mental disabilities. And then the last speaker we'll have is Hattie Coleman. Hattie is a family caregiver herself. She left her job about 6 years ago to care for her mother, and Hattie will talk about her personal experience and share that with us. So we've got a great group to speak today, and we're really looking forward to hearing from all of them. So let's turn next to the polls, and we can see a little bit about who is part of this. So that's the agenda for today. We'll go through these polls. So let's just move to the right poll. So which of the following best describes your professional area? Just choose one: health administration, medicine or nursing, pharmacy, social work, advocacy. Are you with a health plan? Do you do policy research or other? And just take a minute to fill those in. Maybe about seven more seconds. Just choose one that's best. Great. Okay, let's look at the poll results now. This is great. So this is, you can see from the poll results, 40% are in social work. It's got a great distribution with folks in some clinical medicine or nursing. That's terrific. Some health administration and advocacy, and a number of people from health plans. Great, thank you. So the next poll. Describe what your primary role is. I mean, we have many roles, as we hear from some, but are you an administrator, a clinician? Do you do education research? Are you a consumer advocate? Is your role as a care coordinator? Are you a family caregiver or something else? So again, take a few seconds to choose what you think best represents your primary role. Okay, a couple more seconds, and then let's turn to the poll and see the poll results. Great, great. So it's not surprising. We have a lot of people who coordinate care. It's great for this webinar. Some family caregivers, consumer advocates, and then clinicians, administrators, and researchers. Great. It's a real diverse participation. So we have one more poll. Let's switch to the next slide. And now talk a little bit about, just tell us what setting you work in. Do you work at a managed care organization? Are you in an ambulatory care setting, long-term care facility? Maybe you're with a home care agency or community-based organization or some other organization. So take a look at those. Choose what best represents the setting you work in. A couple more seconds on that. Great. Okay, let's just see the results of this one, this poll. Great. Okay, yes, not surprising given the audience here. We've got about a quarter of the people with managed care organizations, some in community-based organizations or ambulatory care, a number of people with long-term care, home care, great, and some academic researchers and a number of others. So we're clearly love to hear a little bit more about who you are in the other category at some point. So thank you. Good. We have a great representation of people. We look forward to your questions. And now let me turn it over to Dr. Anita Major, who will start off our presentation. Thank you.
Carol. Thank you, Carol. Next slide. As we face the demographic changes that are occurring in this country, it's increasingly important to recognize that our aging population will obviously require help. In fact, 80% of elderly Americans requiring long-term care currently live at home or in the community, and unpaid family caregivers provide 90% of their care. When we think about government expenditures, $66 billion were spent on Medicare and health in 2015. Compare that to the incredible $375 billion that caregivers saved the government in spending. Recently, the term sandwich generation has been coined. This refers to caregivers who are sandwiched between the needs of their children and those of their aging parents. I am part of this group, as are the majority of caregivers. Balancing these competing interests of dependent family members complicates caregiving further. Next slide. How do we identify caregivers? They are not always relatives. They do not always live near the care recipient. Sometimes they are paid, but often not. Sometimes they themselves are elderly and suffer from disabilities. Regardless, we endeavor to educate, empower, and assist caregivers in all that they are tasked with. They will strive to meet the financial, emotional, social, functional, and medical needs of their elders. The image of a superhero coming to the rescue sums up all that caregivers take on. Next slide. Here's where the superhero analogy really makes sense. The mnemonic is DECAF. D, caregivers can be asked to assist with direct care provision, which might include bathing, dressing, and toileting, which are activities of daily living, or cooking, doing the laundry, managing medications, and even medical therapies such as nebulizers or tube feeds. These tasks are physically challenging. Next is E, the emotional support that elders require as they come to terms with their own decline in function, their own loss of independence, or even social isolation or depression. C stands for care coordination, which is not only navigating the healthcare system, but also determining how and when to transport care recipients to those services that have been arranged. A is for advocacy, which is a crucial task that caregivers undertake. Elders that require caregivers are by definition vulnerable and often cannot communicate their concerns or preferences. Last but not least is F, the financial commitment that caregivers make to ensure all necessary medications, equipment, and supplies are available to the care recipient. Next slide. One of the first lessons I learned in geriatrics is to get another perspective when taking a history. Can we advance to the next slide, please? Thank you. Oh, that was 2 slides. In any case, initially I would speak to the patient directly upon meeting him or her in the emergency room, but then I would always try to involve a family member or friend to either corroborate what I had already heard or add to my understanding of the situation. The same principle applies with care planning. And as with all things in medicine, before we make an intervention, we first have to make a diagnosis. I apologize for how clinical this sounds, but I utilize this concept on a daily basis. When I teach medical students, for example, my initial step is to find out what they already know so that I can best tailor my educational efforts and maximize learning. Next slide. An important term commonly being used in the caregiving literature is Dyad. This refers to the combination of the care recipient and the caregiver and conceptually links them as one entity. A critical first step in assessing the Dyad is identifying what they understand about their situation. What do they know about their chronic medical conditions? Do they have realistic goals and expectations? Do they know what to expect as diseases progress? Knowing the context of the Dyad is also important. Who makes up the family unit? What is the financial status of the Dyad? What has the duration of caregiving already been before you actually get to meet them? Clarifying goals of care and how the Dyad wants to be helped is essential in guiding care planning. Lastly, there is meaning in every relationship. What was the nature of the relationship between those in the Dyad before now, and how has that changed over time? Diagnosing the dyad should be a systematic process of gathering information to identify the specific problems, needs, strengths, and resources of the caregiver, as well as the ability of the caregiver to meet the needs of the care recipient. Next slide. In medical education, we utilize the SPIKES protocol as a framework for delivering bad news. I find it useful in caregiver assessments as well. First, the setting should be optimized, and ideally this means separating the caregiver from the care recipient so you can have an honest, open discussion. P stands for perception, which is assessing what the caregiver perceives about the diagnoses, prognosis, and his or her ability to provide care. The I is not so relevant, so we'll skip to K. And K is knowledge. This is where any clarification about misperceptions should occur, thereby educating the caregiver and imparting knowledge. E is empathy. We may not all be caregivers, but certainly we can see that these caregiver superheroes have taken on a difficult, complicated task. I believe that the P, perception, and E, empathy, are the most essential components of the SPIKES protocol as it relates to caregiver assessment. Next slide. Caregivers are not always gradually introduced into their roles. For example, in the wake of Hurricane Harvey here in Houston, we have seen elders who were previously able to live independently now lose their homes and suddenly require assistance and even relocation. So being aware that caregiving might be an acute event rather than a long-anticipated one, you can see that the caregiver might have limited knowledge of the care recipient's health issues. As an extreme example, rather than asking, how long has your sister had HIV? It would be better to ask an open-ended question such as, tell me what you understand about your sister's medical conditions. You can imagine it might be possible that the caregiver not even be aware that her sister had ever been tested for HIV in the past. Again, it sounds so clinical, but remember, you're trying to diagnose the perceptions of the caregiver. Your task here is to listen. Next slide. Further probing might be necessary. Anticipating the needs of each dyad is impossible, but another question I often ask is, what do you find challenging about managing your family member's health? This opens a dialogue whereby the caregiver can introduce his or her own concerns. Next slide. Think of the caregiver as a critical extension of the formal healthcare system. The efforts of a caregiver are the most important predictor of how well the care recipient will do. Complications such as pressure ulcers, malnutrition, and recurrent hospitalizations are more likely to occur if the caregiver is overwhelmed and underprepared. To maximize the effectiveness of the caregiver, it is essential to help him or her feel supported in his or her endeavors. I mean, even a superhero needs a little bit of love. So please don't underestimate the importance of empathy. Next slide. Caregiving is hard, and sometimes people aren't open to talking about it initially. So if the care recipient doesn't bring up anything when you ask, consider asking probing questions to delve deeper. As we mentioned earlier, tasks related to actual caregiving can be physically taxing, but there can also be non-physical manifestations of stress also, and this is probably what we see more of. As an aside, we should also be mindful that caregivers, when placed in that role, can actually flourish. Although less commonly seen than more of the negative emotions, we sometimes see that people have improved self-esteem and they feel better about themselves because they've mastered something and are making a difference. Next slide. The bottom line is, when we start to ask questions and listen, then we can begin a dialogue that has the potential to last years. In this process, we also begin to normalize feelings of anger, sacrifice, and fear, which can be reassuring to caregivers as they move forward in their role. Next slide. In the next few slides, we will briefly review some of the instruments that can be useful in caregiver assessments. The Zarit Burden Interview is a validated objective measure of caregiver burden. It was initially designed for dyads dealing with dementia. The long version consists of 22 items, but a shorter version also exists. And I would like to highlight a few items. Asking if caregivers don't have enough time for themselves, if they feel angry, or that their own health has suffered are aspects of this instrument that are important in normalizing these feelings. Next slide. The burden scale for family caregivers was initially developed in Germany and has been translated into 20 languages. It is not specific to dementia as the Zarit was. It is a 28-item questionnaire, and I like that it includes not only negative aspects, such as feeling forced to be a caregiver, but also positive feelings, like being acknowledged by others and even feeling joy. Next slide. The American Geriatric Society has another caregiver assessment, which not only asks about difficulty concentrating as a sign of feeling overwhelmed and positive aspects, such as feeling useful, but it also attempts to hit on an emotional facet of caregiving. There is a question asking if it's upsetting to see that your relative has changed so much from his or her former self. Specifically for care recipients with dementia, there may be feelings of loss as the care recipient seems to lose all psychological attachment to the caregiver. I mean, imagine taking care of your parent with dementia who no longer recognizes you. Dementia can also be complicated by behavior issues like spitting, biting, screaming. These behaviors must have a psychological impact on caregivers, and they may be dealing with these feelings internally but not have an outlet within which to discuss them unless we specifically ask. Next slide. The needs and capacities of each dyad will vary, and if you keep in mind, again, a very clinical concept of diagnosing them, what they need and where they need to be, you can help fill in the gaps for them. Next, we'll hear from Allison Dobecka, who's going to take on what you do next once you've identified some caregiver needs.
Hello. The first thing we're going to talk about is readiness to learn. There are roles for the learners as well as the teachers. The first role of the learner will be to be receptive, willing, and able to learn. But the role of the teacher is going to be understanding these needs. As busy as we may be when we're in our teacher role, we must be willing to stop, and no matter how much we think it is important that they learn, if the learning is not going to be effective. But I would like to say that I feel that this is very rare. Oh, next slide, please. I would like to say that I feel like this is going to be very rare, and there's rarely a time when there isn't something that a learner can take on. Finally, we have to remember that timing is everything, and this is very true in teaching. We need to make sure that the physical and psychological comfort is assessed to start with, and making sure that this is the right time to teach patients, make sure that we're not wasting not only our time nor theirs. Next slide. So we can use the mnemonic PEAK for this assessment. First would be for physical readiness. As we heard about earlier, is the task that we're asking caregivers to complete going to be affected by the caregiver's height, weight, age difference, the physical demands of a bedbound or totally dependent care recipient can be daunting. That would lead us to E, the emotional readiness. We're going to talk about in a minute the support system of the care recipients. And does the caregiver have a large support system, a small support system? Do they have anxiety of their own? What is their developmental stage? I know I have caregivers who sometimes are either a lot older than the care recipient or even a lot younger in where they are in their developmental stage for understanding this. The next D is experimental. What are their coping mechanisms? How do they feel that they have control over this situation? And what is their orientation of the situation? Is this a child who has lived a long distance away for many years, or is this someone who has lived maybe even with the care recipient in the same house? The knowledge would be the last one, and assessing that is very obvious, I would think. But in my own role as a nurse, sometimes I've had caregivers who are also in the healthcare profession, and I assume that they may know something that we should never do. Also making sure that they don't have different learning styles, written learning styles as their what they prefer. Would they like something to be written, verbal, or maybe sent home for them to read later? Next slide. We all know the saying, it takes a village to raise a child, but the same can be for this patient population. We've already heard that the family caregivers make up most of who provides this care. Just to say this again, the informal caregiver are usually unpaid. They could be the spouse, partner, family member, friend, neighbor. And only 1 in 4 of these caregivers is going to get some sort of extra help from our healthcare system. And again, the value of these services to these care recipients is massive. In 2013, it was estimated to be $470 billion. Next slide. So what can we do to help? We must get creative. The inner circle, of course, is going to be what we need to investigate. I encourage them, my caregivers, and even if the care recipients are with them, to think, list, brainstorm, immediate family, extended family, friends, trusted community members. We can move outward into our community, religious organizations, nonprofits, such as Meals on Wheels in many communities, organizations such as the Alzheimer's Association, Parkinson's Association, American Heart Association, for resources, not only for disease processes, but the resources in the community. The private or formal caregivers, private pay caregivers, is sometimes an option and can be explored. I know it's in Texas, we use the Department of Aging and Disability often for caregivers, but that will have a financial requirement. Finally, I encourage patients, especially in what we heard about the sandwich generation, to use the web to coordinate care. You can start very simple and using Word documents to email calendars or needs out to group text messages. I know people can use Google Docs or shared doc systems to make sure that everyone in this inner circle is informed of the needs. But then you can also think broader, Facebook, social media. There's a lot of support groups out there. And then there's also scheduling apps or scheduling websites, which are free. And this really helps coordinate a group to be on the same page about the needs. Next slide. These are 2 online resources that I have recommended and have also used personally. On these, there's usually a care coordinator who sets up the website, and you can put, for example, on the Lotta's Helping Hands, you can put requests for someone to drive the care recipient, make meals, put special occasions so that everyone's aware of. And I know the Lotta the Lotta Helping Hands has an app as well. Next slide. So with these websites and just in general, we need to have a leader, a coordinator, a ringmaster, someone who's in charge and someone who's going to make decisions. And Fiona's going to speak to that in just a little bit. But I think it's important to note, is this decision maker going to be present and available? Is this person going to have the ability to use the phone, email, the web to coordinate the help needed? For example, let's say the head of a family is an elderly wife and the care recipient is the husband. Can she coordinate all of this? Or maybe is there a daughter or a son that would be better able to handle this task? And this person should be able to be the delegator. Finally, speaking to this leader or coordinator and giving realistic expectations is, I think, very important. There was a caregiver survey from AARP, and they asked caregivers to identify the main problem with the person they were caring for. And the number one response was old age. So these caregivers didn't know the exact disease process they were taking care of. For example, if a patient is diagnosed with early dementia and their life expectancy may be 10 years, this might have financial impact to decisions that they make. Or if there's a progressing neurological disease and the family sees or the caregivers see that the patient's walking now, they might not understand that they may need assisted devices, mobility aids in the future. So if the caregivers are trying to decide where this person should age, and one family member has a first-floor house with a bedroom and a bathroom that's easily accessible, and another family member has a second-story townhome, if they understand that these future needs may change, they may better make decisions now. Next slide. This is just a very brief case study of a 92-year-old I take care of who has Alzheimer's dementia. She had a pelvic fracture and has a history of extreme anxiety. She has six sons and one daughter, and she's lived with the daughter for many years. The daughter's also a small business owner, so she usually wasn't present for my appointments, but she is the primary decision maker. So while she would set up a schedule for her family to take care of the patient, even though I would be with the brothers or a sister-in-law during my visits, I always knew that I needed to call and check with the daughter, the primary caregiver, the primary decision maker, and the leader. When this burden for 24/7 care became too great, they were able to pool money and send patient to a respite care 2 or 3 times a week. Next slide. And this leads us to different support systems for our caregivers. Respite care was one of them. I spoke earlier of the Alzheimer's Association, Parkinson's, American Heart Association. Not only do they have information about the disease processes, but they often have education and training programs. They have support groups. And I know in our area, in Houston, the Alzheimer's Association, they even have classes for the care recipients to attend while the caregivers go to support groups or to training classes. There's also home modifications that often can be provided by churches or Boy Scouts, transportation. I know we have a van service in our area that we help coordinate or set up our patients with. And then I'd also like to speak about family meetings. I know this can be very time-consuming, but these can give you big rewards by finding out the leader, making sure everyone's on the same page. And in these family meetings, you may find that there's different cultural expectations of aging that might come up that you didn't know about before. Next slide. In the August 2017 gerontologist, there was a study done that showed that while African American and Latinos may expect less age-related functional decline, Koreans and Chinese cultures usually expect more age-related functional decline. So there can be a difference in perspective in that can come out when doing these assessments. The traditional gender roles, in the last caregiver survey in 2015 from the AARP, they did say that still 60% of caregivers are female, but that means there is 40% that are male, and different issues regarding just everyday care of a son taking care of his mother, being able to openly assess that his needs or his questions is important to make sure that everyone gets adequate care. I do house calls, and so I see multi-generational living probably more often than in a clinic setting. I think it's great. We all know that children do better when they're living with their grandparents, and there's many rewards from that, as well as from the grandparents. But there is a safety assessment that I think is important to bring up, meaning children around different equipment and medication, making sure that it's secure and safe, and also fall risks, toys, things that are out, making sure that care recipient is in a safe environment as well. We heard about perceptions. I just would like to speak about perceptions of placement. Again, open-ended questions is always good. How has previous family members or close friends aged? What do you consider aging in place? For some people, that may mean care recipients staying in their own home, moving to family members' home. In some cultures and in some communities, I've had caregivers who have never known anyone to move to a nursing home, and so they don't know if that is an option for their culture or community. And I think that's when it's important for us to educate on the differences between assisted living facility, personal care homes, nursing facilities, specialty facilities, memory cares, etc. And then again, asking open-ended questions about their previous experiences with people who are aging. Have they had positive or negative experiences when going to the hospital? Have they ever known someone who has been on hospice, and understanding that perspective? Next slide. And in summary, assessing the readiness to learn is essential, and making sure that we educate our caregivers on what the help is available. And of course, our goal is to implement a tailored strategy that aligns with the family as well as the care recipient's preferences. And I will turn it over to Siona Regev, one of our social workers.
Well, good morning and good afternoon. My perspective is a little bit different since I work in a geriatric outpatient clinic, and so the focus is going to be a little bit different from the patient's perspective, and then how does it impact on the caregivers. So in our clinic, we see about 250 patients each month, and the majority of our patients live in the community by themselves. They may have some kind of support system, whether it's a provider through the state or through family members. Sometimes it's long distance, but the majority are in their own homes, apartments, by themselves. And what we've noticed, and I've been here in this clinic for a long time, is that the majority, I would say 80%, even more than 80% of our patients suffer from some form of cognitive impairment, and to various degrees on the gradient. For those who have maybe mild cognitive impairment to those who have advanced dementia to the various degrees. So it really impacts the way our patients present themselves, what do we need to do in order to evaluate and determine what will be the best intervention based on the presentation at any given time. Next slide, please. Next slide. So when we talk about cognitive impairment, usually it's really not a dichotomy, but usually we either see mild cognitive impairment among our patients, or we see some form of dementia when that is diagnosed, which is, in many cases, translates into partial capacity. We do perform here decision-making capacity in our clinic, and so this is on the gradient when the majority of our folks, our patients, suffer from some difficulties in their decision-making capacity. And we can talk more about that and how does it impact, again, caregivers, or what do we need to do. So when we talk about mild cognitive impairment, or MCI, the majority of our patients, when they tell us that they are forgetful, they're very, very functional. I had actually a patient just the other day, 60 years old, very vibrant, very independent, very, very functional with her ADLs and all of her IADLs, yet she proceeded to tell me that in the last few months she's noticed that she's forgetful with her short-term memory, that sometimes when she cooks, she forgets to turn off the stove, that sometimes when her husband reminds her to do things, she doesn't remember, and she doesn't read anymore because she cannot retain information. Otherwise, she's very, very functional. So this is usually presentation that most of our folks, even when they're mildly cognitively impaired, do not come forward and say to our doctors or to their family members or to their loved one, hey, I think I have a problem with my memory. It's rare that someone is coming forward that is aware, that is really seeking some professional help to try to enhance their quality of life. Majority of patients do not, and that is the challenge that we're facing. So partial capacity. So usually when patients come here and they may have already some form of dementia, or we may diagnose them if they're new to the clinic with early dementia or more advanced moderate dementia. Again, it can be Alzheimer's disease or vascular dementia or other types of dementia. Usually what we notice first is that there is some impairment with their personal care and hygiene. There is some impairment with their functional abilities, with their ADLs, and mostly IADLs, which is the instrumental activities of daily living. So they may still be able to groom themselves and maybe dress themselves and ambulate and do all their personal care and hygiene, maybe not as good as we would like to think, but they may fail taking their medications correctly, or they may fail to remember to pay their bills on time. Next slide, please. That is when we see some red flags among our patients. For established patients that have been coming to the clinic, when new patients come to the clinic, by the way, we do conduct a geriatric comprehensive assessment where the clinicians will do their physical exam and myself will do a comprehensive geriatric assessment that includes also their cognitive assessment, their functional assessment, and their mental health assessment. So for established patients, if we notice that there are some changes with their personal care and hygiene, we notice that there is a change. If there are stains on their clothing as such, we know something has changed. If we know that there's some weight loss and there is no explanation whatsoever, medical reasons for why they've lost weight, and we see that consistently, we know that this is a red flag to look further. Why is it? And usually the issue is that we've noticed is that patients forget to eat. Either they don't have the appetite to eat, or the food is there, but they're not able to go through the motions to heat up their food or to remember to eat. That's executive dysfunction. Sometimes they're just worried, they're concerned, or they're isolated. They pull everybody away from them. Mostly for those individuals that have some mental health issues that have been trying to manage and hanging by themselves for a long time, and now they may also compensate and they start being compromised because they may have some executive function or early dementia, cognitive impairment, and they try to push away their loved one, their family members, their support system. Sometimes they're ashamed. Sometimes they don't want anybody to get close because they're afraid. They're afraid of loss of their independence. Next slide. And so what do we need to look for? And this is really important. I think that the main concern is that if we notice that patients come to the clinic with the same issues, their chronic comorbidities, whether it's diabetes that is uncontrolled or hypertension or congestive heart failure and so forth, and regardless of what we recommend and how we educate them or their loved one, they keep coming back with the same symptoms, or they end up having multiple admissions to the emergency room, and we know that the issues are not resolved, and trying to think what is going on. Why is it that there is no follow-up? What's going on in their homes? So what's happening that they're not able to follow through? So sometimes it's a matter of not understanding the instructions, or they may have some cognitive impairment, or they may have, which includes executive dysfunction that inhibits them of following through. We usually tend to label them, and I hate to say this, but we hear it all the time in the medical field, as non-compliant. Those patients have a reason for the fact that they're not able to follow through. And usually in clinical setting, when they see the doctor, usually for 10, 15 minutes in private sectors, we don't know. The doctors may repeat the same question with the same instructions over and over again, but they're presented with the same symptoms. There is something deeper inside that inhibits them from following through. And sometimes family members share concerns, and that's another way that for us to know when I get calls from family members and telling me, hey, my mom is more forgetful, my mom is now, I think that she's financially exploited, the bills are not paid, she's giving cash to such and such to her provider, and there are some concerns, and this is coming to our attention. What should we do? So where do we go from here? Next slide, please. So resistant to change. So what is it that inhibits our patients? Why are they resistant to change? And as I mentioned earlier, I think that the main thing is self-determination, the need for being in control. For many of our patients, they want to stay in their homes regardless of how compromised they are. This is what's familiar for them. They don't want anybody to interfere. They don't want to reach out to people, to family members, caregivers, and so forth, because they're afraid. They're afraid that someone is going to take away their rights. Someone is going to take their independence away from them, or place them in a nursing home, or take them to the hospital. They're afraid, so they rather push people away from them or not deal with it. They're just not going to the doctor until it comes to our attention one way or another. So I think that's the main thing, is fear of losing independence. And what we see mostly is that those individuals, the manifestation of their behavior or their home situation is self-neglect. The majority of the cases, I would say from studies that we've done here in the county and within the hospital, I would say that at least 85% or more of cases that are reported to the state, even nationwide, are diagnosed among the elder mistreatment categories with self-neglect. And that is the group that is harder to detect and is the harder to intervene, because those are adults. And usually the manifestation, again, is within the partial capacity, where they have still a sense that what they want, they can express it, but then they have some gaps in execution and in the way they do take care of themselves. Next slide, please. So where do we go from here? I think that the main thing is to try to work with the patient, with the person who is presenting those manifestations. And so what we try to do is build a rapport and try to work step by step with our patients by telling them how much we care about them, how much we're concerned about them, and yes, they're not going to a nursing home. This is not why we're doing an evaluation of their cognitive abilities, or I have to do a reevaluation because they're concerned, because we need them and try to work with us to take care of them, to help them enhance their quality of life. And I think that's the key component that we're trying to promote. It's about your quality of life. It's not about what I want, but it's to better serve you so that you can stay in the community, in your own home. And so that's the first thing that we keep emphasizing with our patients. So that is when our patients come by themselves, when we don't know if they have caregiver support groups. I always ask on an initial visit from the patients, can you give me a name and a phone number of anybody for an emergency, whether it's a formal support system or an informal support system. And then I would ask their permission, usually, unless I'm concerned about their safety, may I call such and such. Next slide, please. So how can we manage, overcome challenges that we have and try to engage caregivers or engage the recipients or the patients? So in a specialty clinic such as ours, what we try to do is, as I mentioned earlier, is conduct an initial assessment on baseline, and then we'll have close monitoring, especially when patients exhibit some red flags, and we want to see them on a regular basis. We also work as a team, so it's really important for us to communicate among ourselves. What happens in regular clinics, I would suggest that either the patient or a family members will reach out to the doctor and share concerns and ask maybe that they would be evaluated for depression and or dementia, or make a referral for a specialist, whether it's a neurologist or a geropsychiatrist or a geriatrician, just to look further into what's going on, because that is a change. Next slide. So what do we do? How do we intervene? I think that the main thing that has been very powerful, especially in our clinic, is to try to engage the caregiver in the process of evaluation. So if I have the family member be present during the cognitive assessment, the psychosocial assessment, the mental health assessment, they notice when their loved one have difficulties, they struggle with orientation to time. And I do ask very, very casual questions and try to tailor it to the educational level of the individual. So those questions usually and the task that they have to follow are very, very basic. So if they notice that they have trouble with short-term memory, with processing information, with recognizing shapes, or following through, such as drawing a clock that it slumps, it's one of the references that we have later on in the presentation, they're noticing there are some red flags. Also, when I do conduct my psychosocial assessment, I also ask questions about their history. So we look into the long-term memory and the current memory, and I ask questions about demographic, where do you live? So those casual questions can raise flags and bring awareness to the family members. Yes, something has changed. For long-distance caregivers, it's important that we communicate different modes, especially now with technology. There are many ways that I communicate with family members, via email, via telephone conferences, and so forth. So it's really important to finding a balance between the patient's rights for self-determination, how much can we engage, how much do we need to be involved. And it's really a fine line, how far do we go, how far do we push, and how much can we allow for the patient to continue engaging in their functional abilities. Next slide, please. So the case study, I just wanted to share a story real briefly about a patient that actually right now it's a couple, they're both in their 90s. She's diagnosed with advanced Alzheimer's disease. The husband has been the caregiver. He himself is frail with cardiac problems, mobility, physical deconditioning, and he wanted to be in control. 3 daughters are involved or semi-involved, living in different continents. The daughter that lives here, whom they live with, they've been having tension between them. And so the husband really did not want the daughter to be involved, number one. Number two, the finances have been depleted slowly. And so there's been a challenge in how to allow or try to convince the spouse to get some help from us and from the state, and how to allow the daughter to step in. So I spent a lot of time with the spouse, who later on became actually one of our patients. So both myself and our geriatrician have spent a lot of time trying to cultivate the relationship, build up support, and eventually the wife became a U.S. citizen and has been receiving provided care, and we're right now looking into trying to get some help for him. Next slide, please. Actually, we're going to move to the HIPAA. So next slide, number 48, please. Thank you. So I'm shifting now to another issue that I think has been a challenge within our clinic, and that is with our patient, and that is how to navigate and how to access systems, whether they're in the local arena, state, or federal. And the majority of our patients have difficulties, not only them, but also caregivers, family members, have difficulties understanding the language and the intricacies that entails in benefits. And I'm going to go further and explain that sometimes the representative on the other side, because of the issue of HIPAA and privacy, they do not allow other family members and or healthcare professionals to intervene unless there is a consent from the patient. Well, what happens when those patients are compensated. They are cognitively impaired or they have moderate to advanced dementia, and there are no provisions for power of attorney or durable power of attorney for health care. What do we do? How do we take it from there? And so, next slide, please. So some of the strategies that I've been using to try to empower either the patients and or the family members is do a lot of education, share with them some written instructions if we have a family conference. So I will guide them in advance, the family member caregiver on the phone, and in terms of the language, in terms of what kind of information do they need to share so they are prepared, whether it's Social Security number, Medicare number, and so forth, demographic, and also what to ask for. I also try, on the other end, to try to educate the agency representatives, the sites. Usually they're young representatives. They follow a protocol that is very regimented that they have to abide by. And I try to explain to them, try to think out of the box, try to be a little bit more flexible, because we're dealing with patients that either don't understand what you're saying, they cannot hear you, they cannot process, so you have to slow down. So I see myself as being an educator and try to work and navigate the system step by step with a lot of instructions and guidance on both sides. And just to give you an example, which is next slide, please, and that is a simple example that I encounter nearly every day, where patients come in and all of a sudden something's changed. They are trying to get their medications, and either they don't remember what kind of a drug plan do they have, or they did not enroll in a drug plan, Medicare D plan. Or I had a situation the other day of someone who had Medicare, Medicaid dual eligible, and now she's getting her widow pension, so no longer is dual eligible. She's back to Medicare, but it's in transition, and right now she doesn't have the benefits that she needs to. So my role is to try to call Medicare, try to educate the caregiver in advance on what we're doing, what do we need to look forward to, and then while we're having the conference call with Medicare, to have consent so they can talk to me, so I can ask the right questions. And sometimes it is a challenge, especially if the patient and or the caregivers are not the representative payees, and the representative on the other end are not convinced that they're getting the yes for consent. So that's basically my role. I have added, I think that the next few slides, some tools that we use. This is the screening tools for MCI and partial capacity, number 82, if I'm not mistaken. Next slide. And so these are some of the tools that we use in our clinic in addition to ADLs and IDLs and the PHQ-9 for mental health assessment on depression. I think I do have some references in the following slides in terms of where to get information about these cognitive screening tools, but they have been very helpful for us to conduct in order to get information, baseline information about cognitive abilities, executive function, and capacity, which is the MedSale. It's a tool that we here at Baylor College of Medicine Geriatrics and Harris Health, we developed this tool for our practices. And I think that's it, and I'm going to pass on the presentation to one of our caregivers, Hattie Coleman. Thank you.
Good afternoon. My name is Hattie Coleman. I am 70 years of age and have been a caregiver for my mom for over 10 years. She is now 103 years old. She moved here from Polk County, where she and my dad had been married for over 55 years before he passed away. After he passed away, she continued living in her home for many years until we decided she couldn't stay by herself any longer. She was getting around good on her walker when she moved here. But as time went by, I went through a lot of challenges. First, she had a mini stroke and recovered from that. Thank God it didn't leave her where she could not function. She still was able to get around on her walker. Then dementia started in. Some days good and other days not so good. I had to learn how to deal with her in that condition. When she get agitated, I would just leave her alone and go back to her later. She's really not able to communicate with you except the basics, and this still continues as of today. Then she fell and broke her ankle, and it went downhill from there. She had to have surgery, and that was a hard decision for me to make for a 102-year-old person, which I didn't have a choice. She couldn't communicate, so I had to make the decisions for her. She was in the hospital 2 weeks. Then after the fall, there was a much bigger change in her care. She went from walking on a walker to not walking at all and not able to do anything for herself. So the support I received to keep her at home was a social worker would come to assess her needs, providing equipment and supplies through her insurance company, which was United Healthcare. She developed a bad sore on the heel of her foot, and the home health agency would come to dress her wounds and take vital signs. Her insurance company would offer respite hours. She gets 700 hours a year, which I would take them as I needed. The way I found out about the respite benefit was through a friend that was taking care of her loved one. So I started inquiring about it through Mom's insurance. When the social worker came out to visit her, she explained to me how it worked. The respite care is perfect if you can find a good place. I've had several bad experiences with the places that I left her. Upon picking her up, I found her on the floor, in the dark, with the door closed. I said, that's enough. No one should be treated like that. So I decided to do something different when I have to leave her, and that was getting someone in my home that I can trust to take care of her. And so far has worked out fine. But out of all the support I've had, the house call doctor helped me the most. The doctor would come here so I wouldn't have to take her out for a doctor's appointment. The doctor would take time to talk to me about things that I would face while going through the healing process. I am so grateful that my mom is a part of the house call program because home visits are so important and such a benefit to those who can't get around. Thank you.
All right. Thank you so much, Hattie, for your presentation. And thanks so much to our speakers, Dr. Major, Allison, and Siona, for your presentations as well. This has been incredibly informative, and thanks for joining us today. So we have a few minutes now. We have, just about 25 minutes for questions from the audience. So at this time, if you have any questions for our speakers, please submit them using the Q&A feature on the lower left of the presentation. You can type your comments at the bottom of the Q&A box and then press Submit to send it. All right, so let's see some of the questions that came in. Dr. Major, I'm going to start with a question that was asked during your presentation. And I think, Allison, you might be able to answer this as well. But the question was, are there existing measures used in healthcare that capture the health literacy skills of caregivers?
That is a wonderful question, and it would be a marvelous endeavor. I have not seen anything, and I find that the mix of cultures, of languages, of expectations is so varied that really the open-ended questions tend to work best for me. I have not seen anything objective or any scales that have been validated that attempt to get at that. To understand those kinds of things, you really need a really rich conversation, and I usually use the scales that I mentioned as sort of an introduction to start the dialogue, but those I end up just asking as the discussion progresses. Allison, do you have anything to add?
I would just add that I don't know of any scales, but the time is probably the best thing to determine that, as you were saying, and with open-ended questions.
Great, thank you. And Allison, while I have you, I do have another question that came in. So you talked about family meetings being key to helping families get on the same page. So should you have the care recipient present during these meetings, or just keep these meetings for the team of caregivers?
That's a really good question. I've had family meetings both ways, but I would say typically the family members feel more comfortable and are able to speak more honestly about their feelings, because typically this is a child speaking about a parent, and that has its own dynamics. And so I think while it's definitely up to the group as a whole to make that decision, you would probably get a more open and honest conversation if it's just with the care recipients, in my experience.
Great, thanks. That's a great point. All right, and Fiona, I have a question for you as well. And this came up during your presentation. So the question is, where can someone go for a comprehensive geriatric assessment?
Okay, so we are here in Houston, Texas, in Harris County. So there are, to my knowledge, there are a few geriatric clinics within Harris County. The clinic in which I function or work at has been probably the more comprehensive and the longest of all, and this is with Harris Health, which is a county hospital, in conjunction with Baylor College of Medicine, which is our staff or the attendings. I'm not sure what's available in other counties, in other states. I think that the best thing to do is if the individual, the family member has, or the patient, the recipient, the individual has concerns about their memory, if the primary care doctor is not able to address those issues or doesn't seem to have the tools, that I would recommend that the family members or the individual will ask to get a referral to either neuropsych testing and or to a geropsychiatrist or to a geriatrician or neurologist. So have any of those specialties get a referral because they are concerned. And I think that the main thing that I always share with either the patient or family members, because and it is a great question, because very often the presentations of the patient is that there's nothing wrong with them, and in 5-10 minutes it's really hard to see and look through what's not said or what's the observation. It's really too short. That's why we take more time here. Our evaluation, usually on an initial visit, is 1 hour with the clinician or the doctor and 1 hour with the social worker, myself. Most clinics don't have that leverage or that time. So that's what I would recommend to send specialists. But the main thing is for either the patient, if they're concerned, aware, and or the family caregivers, to keep a log, to write down those things that they notice that have changed, that are different, those red flags. What doesn't sound right with grandma or with mom right now? And based on that journal, share it by email, by phone, or face-to-face with the PCP. and or with a specialist if they're not available. Anybody else has something to add? Dr. Major?
You know, my experience in the healthcare system as a medical student resident fellow and now a clinician, I've always been in the academic realm. And so that's really the only aspect of healthcare that I know. And I know pretty much in any academic setting, you have clinics, usually a geriatric presence, that would do these kind of assessments. I'm sure it's possible, and I'm sure people in the private sector also do a wonderful job. It's just harder for me to know where those are. And certainly I've been asked for help finding people in Atlanta and Chicago and wherever else. And my first thing is to go to an academic place. Whether that's correct or not, I don't know, but certainly they would have it at a minimum, and then I would expect other private geriatric clinics to be able to do these kinds of things as well.
Thanks, Dr. Major. I think that's insightful. Hattie, if you're still on the line, we have a question for you. So the question is, as a caregiver, do you have any recommendations for social workers who are doing the initial assessment in the home or when meeting for the first time? Is there anything that worked better for you when working with the professionals?
Is that question for me or for Dr. Major?
Oh, that question is for Hattie, our family caregiver.
Yes, the social worker was very helpful to me as going about, how to go by getting things for my mom that I would need at home. So it was a very good support for me.
Was it the fact that she came to your home that was helpful, or was it the questions she asked, or the time that she spent, you didn't feel rushed? Was any of that better than what you would have expected if you'd had to go to clinic and leave your mother here?
Right, about her coming to my home.
Okay.
That was a big help.
Thanks, Hattie.
Mm-hmm.
All right, we have lots of questions coming in, and the next one is for Allison. And this is a multi-level question. So one of our participants asked that we talk about care plans and then best practices for, one, communicating and providing to caregivers, and then collecting care histories and health status from caregivers, and then finally, reducing stress, sharing caregiving, and improving communication for caregivers.
Okay, so for the care plans, like I said, I do house calls, so the way I practice is a little different, but I feel that leaving something with the family or the caregiver is probably the best strategy. When I'm in the house and I write my instructions or my care plan, I physically tape it to the mirror, to the bedside table, to the kitchen, to the refrigerator, so that it is somewhere where all the caregivers, wherever they feel in their home, is the best place for everyone to see. So even if you're in a clinic setting, you can make that reminder to them. Don't just put this in your purse and forget about it. When you get home, put this on the nightstand. Put this on the refrigerator. And so I have had families create books to keep track of things, but it's important to show them the importance of your plan. I hope that answers that question. I'll go to the reducing stress. So I was a nurse in a hospital and for many years, and we as nursing talk about often caring for the caregiver, meaning you can't do your best work at the bedside or in a clinic if you're not taking care of yourself, so remembering to eat lunch, etc. So I try to take that concept into the home as well, and oftentimes my visit with a patient may be a small percentage of the actual time I spend total, because families are feeling stressed or guilty for trying to also live their own life, I think that is a time when, as Dr. Major said, the key is listening and also validating that they are also allowed to take care of themselves. I think at least in house calls especially, reducing stress for our caregivers does take a lot of our time. And so even just saying the concept, caring for the caregiver, their eyes can sometimes light up and be as if they had never thought of themselves as someone who needed care for. Collecting the care histories and health status, I'll maybe send that to Fiona because I know she does a lot of that, if that's okay.
Okay, so repeat the question again. What was the question specifically?
Sure. So this part of the question was regarding collecting care histories and the health status from caregivers.
Okay. So it's collecting information from the caregiver. I'm not sure if I'm understanding the question correctly. It's collecting information from the caregiver about their relationship or their.
Yeah, that's how I interpreted the question.
Okay. So I think as Allison had mentioned, my role is to try to be listening actively, to be with the caregiver at all times throughout the journey. At times, since this is a clinical setting, the caregiver is present with the patient. There are times that the patient does not want the caregiver be present, so I would ask gently to separate, and I may have an excuse why the doctor needs to see the patient, and I will take the caregiver to my office so we can have a one-on-one conversation. So it really depends. But I try to, first of all, listen to where the caregiver is coming from and what are their concerns and what kind of relationship have they had with the patient in the past or present, because sometimes there are unfinished business between the patient and the caregivers, and they end up being the only one even though they haven't been close to the patient. So it's really important to recognize and understand where they're coming from and what are they willing to give or how much they're willing at this point. The other piece is to try to educate them about why is Ms. Jones not able to fix her meals? Why is she not able to do so-and-so? Because very often the family members will say, well, she's just not interested. She just doesn't care. And my comment is maybe she cannot do it anymore. Maybe she's not able to. Maybe there's some executive dysfunction. So there's a lot of education going on between myself and the caregiver. The other thing is, as Allison had mentioned, is that I do try to educate them about the fact that our individuals, our patients, are adults. So we try to engage in conversation with integrity and allow them room and space for self-determination, but also give the caregivers the legitimacy that this is very stressful, this is a journey, and it is a process, and it takes time. And sometimes we cannot do a whole lot until further decline is present. And mention to them again that you really have to take care of yourself, as Allison mentioned. There is a need for self-care, and try to do a lot of validation and also try to empower them. So I think it's a combination of education, advocacy, and try to be there for them and make sure that we're accessible, that if they need to, they can call me, they can email me, they can just drop in, which happens. So try to be available at all times. Hopefully that answered the question.
Yes, that's fabulous. Thank you. All right. At this time, Hattie, we have a couple questions for you, so I'm going to ask you another question. So the question is, so it sounds like you were receptive to receiving respite care, but do you have any suggestions for how, quote, like an outsider can go about convincing a caregiver to seek help, such as respite care?
The way I've used respite care, is to give the person that is a caregiver, a break to get away from, because it really is a hard job to take care of someone. So, and the main thing for respite care, if you have to place them somewhere, it's really hard to find. You have to find a good place to put them. Because, like I said, I just had bad experiences on some of the places that I have left her.
Sure.
So just try to pick up a good place if any way possible.
Okay, great.
This
Thank
is
you.
Anita Major. I interpreted the question more as if a caregiver were reluctant to utilize that, how would you discuss it with them? And if that is the intent of the question, then I would add that you would need to, again, get at the perceptions and say, well, what makes you nervous about this? And I will say, as a healthcare provider, sometimes we don't promise the moon, but we say, you know what, I'm going to get a home health nurse in here, and it's going to be fantastic. Or this respite benefit is so wonderful, you should do this. And I have learned to not be so excited about some of these things because the implementation of them is that, I saw someone come to the door and they left a sticky on my door saying, sorry, I missed you, but they never rang the bell. And that was a physical therapist who just came and left and didn't even try to access the patient, right? And so we have all these wonderful things that if they were implemented perfectly would actually relieve some of the work. But sometimes when we ask these companies to help us, it actually creates more stress for the caregiver who is expecting relief and it doesn't come. And so this goes back to getting a care history of asking, what have you used before, what supports have you had, and how did they work for you? But again, if it's someone resistant to utilizing respite, thinking, it's going to be dangerous for their loved one, or they've heard bad stories, or they don't feel like they've earned it, then it's really exploring those questions first so that you can better speak to them about how it might be helpful.
Great. Thanks, Dr. Major. I think that's a really important perspective. And while I have you, we did have a couple other questions directed for you. The one question we have here is, do you complete any quality of life assessments with the family caregivers? And I'm sure our other speakers can speak to that as well.
In terms of like a questionnaire, we don't. By the time we meet people on the house call program, which is exclusively my practice and it's not probably relevant to the majority of who's listening, we do a more open-ended assessment about what makes life worth living. And if someone couldn't do those things, then would that change the way that you make decisions for them? There are certainly quality of life questionnaires that our patients can't necessarily fill out. And therefore, I've never had a caregiver try to do that for someone else, and I've not formally assessed my own caregiver's quality of life. But I feel like the experience, and as Allison said, if I'm here for an hour in someone's home, it's probably 20 minutes I spent with a patient and 40 with the caregiver. So I feel like it's easy in that long time to get an assessment of it, but the majority of who's listening is going to be restricted in their time. And so I, again, would say you're going to get more in-depth information asking general questions than having a questionnaire filled out about their own quality, if I'm understanding the question properly.
Sure. Thank you for that. Fiona, we have another question for you. So the question is, this came up during your presentation about strategies to navigate the system. So the question was, what kind of education do you provide to the caregivers? If you could speak to that a bit more.
Okay, so it really depends on the scenario that I encounter. So, for example, if the issue is dealing with navigating systems such as Medicare or the state or their health insurance, then I would try to prepare or even make a referral for provider services. What I try to do in advance is, first of all, tell them what kind of questions to be anticipated that the caseworker will be asking them. and explain the criteria, what is the state is looking for, so they know the kind of questions to ask. The other thing that is really important, for example, with provider services, is that it's really important that you as a caregiver be present during the interview, during the assessment, because very often when you talk to the patient, if the interview occurs between the assigned caseworker and the patient, most patients will say, oh, I can do everything. I can dress myself, bathe myself, cook for myself, and so forth, because this is what they want. They don't want anybody else in their business. They don't want any help. And very often they suffer from dementia and some comorbidities. So it's really important to educate and empower the family members to be present and to ask and point out the right needs for the patient. And so when I make the contact with the referral, sometimes I would make the contact person as the caregiver. So that's for referrals for the state. The same thing is if we're dealing with health insurance benefits, such as Medicare. So it's really important for me to explain, and I have those actually reference handouts that I share with family members to try to simplify the systems of Medicare and the system of Medicaid. So it's written in very, very simple manner, and I go step by step to show them and give them a copy. This is what mom has. This is what general is. This is what we need to look into, and then try to break it down, because too much information is overwhelming, and they can't read the instructions or the booklets on Medicare. It's really a lot of information. Very often family members or patients will bring me a stack of correspondence from various agencies, and they don't know what to do. So I think education about concrete services. Other thing that I focus in my practice is education for dementia, for those individuals that exhibit cognitive impairment. And what do you need, or psychosis? What do you need to do in order to try to work with your loved ones step by step? So I try to give them information about the dementia or what stage or what kind of dementia and what to deal with. I try to give them education about brain enhancement, especially if there's cognitive impairment, if it's early dementia or mild cognitive impairment. So I do have some exercises and some handouts on how to enhance your memory. I try to give them information about creative ways to deal with the dementia, having some hands-on activities, looking at how can we connect, depending, again, on the level of dementia or mental health issues that we have. Or if we have psychosis, I try to explain to them through some validation therapy, or what's the manifestation, how do you deal with them, and I do some demonstration to them. What's the best way to work with them? So I think it varies on many, many levels. Education of material. Of course, I give them a lot of references to the community, but the main thing is having that conversation face-to-face. I think that's the most powerful that I see beneficial for family members, caregivers, and or patients. I don't know, Dr. Major or Allison, if you have anything else to add?
No, I think what you said is fantastic. I do have one small thing. I don't know that I think it's important to, as we support these caregivers, to let them know that it's a continuing relationship. So you don't have to have an hour face-to-face. You could do 5 minutes and say, I'll check in with you next month, and then another 5 minutes. It's more of a long-term marathon as opposed to that I think we should be striving for, and that is really when some of these issues can surface. It doesn't all have to be all at one time, but I think if we commit to more of a long-standing relationship of support, that we can really make a difference.
And I think that's the beauty of the house call program or the clinic, that we have this ongoing relationship with our patients and family members, that we tell them that we're available on many levels. So I think that's really important. That's a good point.
Great. Thank you. That was a really helpful response. So at this time, if you have any additional questions or comments, please email them to our email address. It's rick@lewin.com. So the slides for today's presentation, a recording, and the transcript will be available on the Resources for Integrated Care website shortly. At this time, the post-tests for this webinar are now open. Additional guidance about obtaining credits and accessing the links to the post-tests can be found within the Continuing Education Credit Guide in the Resource Guide on the left-hand side of your screen, or you can visit the Resources for Integrated Care website. Thanks again to all of our speakers. Have a wonderful afternoon, and thank you so much for your participation.